So let's start. You see that? Name the structure which is labeled as 1. Which is the name of this blood vessel? Yes. Which blood vessel is this? Anybody?
Portal veins.
Exactly. This is portal vein. Now tell me how portal vein is formed.
Okay, sir. It's formed by two veins, superior mesenteric vein and the splenic veins, which combine at the level of duodenum and then enter the liver, and it supply 80% of blood supply to the liver.
Excellent. Very nicely he has given bit of description. Portal vein, okay, is the most important blood vessel which takes blood to the liver. Though this blood is a venous blood, okay, but almost 80% of the blood which is going to the liver is through the portal vein. Hepatic artery, takes rest of the blood. Hepatic artery carries pure oxygenated blood to the liver. Both blood vessels are very, very important. Now, this portal vein is formed by, okay, the combination of splenic vein and superior mesenteric vein near the neck of the pancreas. And then it will climb up towards the porta hepatis from the edge of lesser omentum. We call that free edge of the lesser omentum, also known as hepatoduodenal ligament. The portal vein is there, along with common bile duct and hepatic artery. These are the three important structures which are present there on the free edge of lesser omentum. This portal vein has got two sets of capillary. That is the meaning of portal circulation. One set of capillaries is towards the GI tract, and another sets of capillaries develop inside the liver. Now, this structure is the hepatic artery. So in some other situation, they can simply ask like that, so you should be familiar. And this is the bile duct. So probably this is the cystic duct, which is shown here, isn't it? This is cystic duct. So this is a common hepatic duct. Common hepatic duct. Now, number 2, identify the nerve which is labeled as A. Which nerve is that? Anyone? Which nerve is this one? This nerve.
Sir, I think it's a median.
You think it's a median nerve, and you are absolutely
Yes.
correct. You are absolutely correct. This is a median nerve. Now see this, how to recognize it. Median nerve, see this, C5 and C6. This is the upper trunk or the superior trunk. C7, middle trunk. C8 and T1 is the lower trunk. Now these are the anterior and posterior division. Anterior division and the posterior division of each of the trunk. See this. The superior trunk is divided into anterior and posterior division. This is again anterior and posterior division. This again anterior and posterior division. So all the three posterior division will combine to form, see this, okay, the lower cord, isn't it? The posterior cord, I should say. This is in the lateral cord, okay, and the medial cord, the 3-1. So this is how a median nerve is formed. This is the median nerve. And where median nerve will supply? Where? Especially which muscles are supplied by median nerve?
Sir, it supplies our thumb, index finger, and the middle finger area in the half of the fourth finger on the palm surface anteriorly.
Good. And
it supply the
good.
Also supply the hand muscles, the thenar muscles, and other muscles
Good.
are also.
Good. So median nerve doesn't supply anything on the arm. Okay? It doesn't supply anything on the arm. Means above the elbow, it doesn't supply. But below the elbow, especially on the forearm, it supplies a lot of muscles, especially the frontal aspect or the anterior aspect of the forearm muscles, okay, are supplied mainly by median nerve on the radial side. Of course, on the ulnar side, it is supplied by ulnar nerve. Apart from that, the hand is important question for you. Hand, the thin arm muscles, except adductor pollicis, are supplied by median nerve, and first and second lumbricals, okay, so supplied by median nerve. So these are some of the important questions. Number 3, name the area of the brain which is labeled as 2 here. So please see very carefully and answer, okay? Many of the students make a mistake here. What is the name of that area?
Pre-Xerus.
Yes?
Pre-Xerus area of sensory for sensory. So,
You mean sensory cortex?
yes, sir.
Okay. Anybody else?
Yes, sir. It is primary sensory area, post-central gyrus.
Post-central gyrus or primary sensory cortex. Okay. Now see that. Now why it is primary sensory cortex? Now there is a small clue for you, and that clue
Yes,
is
sir.
which is the frontal part of the brain or frontal lobe of the brain, and which is the occipital lobe of the brain. If you recognize that, then your answer is very, very easy. So remember this. This is the frontal
Yes, sir.
lobe. This is the occipital lobe. This is the temporal lobe. So if you identify that, then of course this is the central sulcus. This is the precentral gyrus. This is the postcentral gyrus. Precentral gyrus is the primary motor cortex, and postcentral gyrus is the primary sensory cortex. So in the next question, or next time, whenever you will ask this type of question, you may be asked this one. So please recognize this by this type of way. Do not simply mug up, oh, number 2 is like that, number 3. Hey, never study like that. Okay, identify these important areas, then you'll never forget. Now question number 4, name the structure which is labeled as 16 here. So where is 16? 16 is here. See this. So which structure is this? Yes.
Sir, it is one of the ossicles. Its stapes.
Yes, yes, yes. Very good, Eunice. Any other student? Anybody? This is a anyone can join here. Okay, anybody. Don't feel hesitant. This is stapes. Is absolutely right. This is a type of ossicle.
Sir, it's round window.
Yeah, this is stapes. So this is malleus. This is incus, and here is stapes. So please mute yourself because I can hear a lot of noise there. Okay. Now here is malleus, this is incus, and this is stapes. This is called foot plate of the stapes, which is attached with the it is attached where? What is this structure called? What is this?
Cochlea.
Vestibulocochlear.
Cochlea to the.
Exactly. You can simply say it is attached to the cochlea. That would be enough. Name the structure which is labeled as 1. This bone, which is labeled as 1. What is the name of this bone? Okay, exactly this bone. Anyone?
Sir,
Yes, yes, please
sir,
be louder. Yeah.
sir, I think it's navicular, sir.
Sir, talus.
Okay. So I can get, I am hearing 2 answers here. One is talus, one is navicular bone. Anybody else? Now see here. This is talus, okay? This bone is talus. This bone. This is calcaneum. This is calcaneum or calcaneus, whatever you want to say. This is navicular bone, is right. This is navicular. This is a boat-shaped bone. This is navicular. And here is a cuboid. So this is called navicular bone. So what is the lesson here? What I am telling you is revise the name of the bone which are present in our hand and foot. Revise the name of those tarsal bone and metatarsal bone. Okay, and carpal bone as well as metacarpal. Metacarpal are quite easy, or metatarsal are easy, just number 1 to 5. But tarsal and carpal bone, they have specific name. So it is advisable for you to go through it. Now let's move on. In this picture, which number is showing the area where facial nerve nucleus is located? So you need to see where exactly the facial nerve nucleus is located and which number is showing that area. That you need to tell.
Sir, 10.
11, sir. 11.
Yes, please say it again.
10.
11.
11. So which area is
11, sir.
Yes, which
Pons.
area?
On.
Pons. Excellent. Facial nerve nucleus is located in the pons, and number 11 is showing us the pons here. So this area is pons. Absolutely correct. Okay. Number 12 is showing midbrain. Facial nerve nucleus is not in the midbrain. And okay, probably this is showing the upper part of the medulla. So the exact one is 11 one. What is the name of the structure labeled as 9 here? This muscle which is shown by the number 9. What is this? Labeled by 9. What is the name of this muscle? Anyone?
Latissimus dorsi muscle.
Latissimus dorsi muscle. Yes, latissimus dorsi. Okay, absolutely correct. This is latissimus dorsi. Right? These muscles are gluteus maximus. These muscles are, what is this muscle which is shown by number 7 here?
Rectus muscle. Rectus abdominis.
Very good. Rectus abdominis. Very commonly asked question in the exam. Rectus abdominis. And the muscle which is shown by number 1, what is this?
Pectoralis major.
Pectoralis major muscle.
Pectoralis major muscle. Excellent. Pectoralis major muscle. Yes. Now let's move on. Now see there, another question. This is the dissection of a shoulder region. Identify the structure which is labeled as H here. This area. They're asking the name of this area here. What is the name?
Coracoid process.
Coracoid process of scapula.
Coracoid process of scapula. Absolutely correct. This is called coracoid process, and this is the acromion process. So these are two important process or pointed areas of scapula. Coracoid and acromion. Coracoid process is not attached with any other bone. It is free. Whereas acromion process is attached with the lateral end of the clavicle. So coracoid process of scapula. Absolutely correct. Now, question number 9. Name the structure labeled as 2. So where is 2 here? It is right there. So which structure is this? Anybody? Write this right here. This structure. Yes?
The inferior.
Say it again.
Sir, inferior ganglion, sir.
No, this is not a ganglion.
Interior.
Okay, anterior. What you call that specifically?
So that is a motor area, sir. Motor.
They are right. These are the motor nerves. Very good. Motor nerves. So these are known as ventral root of spinal nerve. Okay, ventral root, or you can also call them anterior root. Anterior or ventral root of the spinal nerve. These are called dorsal root. See here, dorsal root is associated with the ganglion. This is known as dorsal root ganglion. But in the ventral root, we don't have any ganglion there. Okay, so both of these combine together and form a spinal nerve. So this number 7 would be spinal nerve. So next time, don't be surprised if this type of question is asked to you. Number 7 is spinal nerve. Number 6, dorsal root ganglion. Number 2, ventral root. Number 1, dorsal root. So these are some of the important points here. And he's right, ventral root only carries the motor nerve, dorsal root only carries the sensory nerve. And when a spinal nerve is formed, both are there now. So it's a ventral root of spinal nerve. Now number 10, name the foramen of the skull which is labeled as 10. It may be a bit difficult for you, probably. Okay.
Sir,
Yes,
sir, it is jugular foramina, sir.
exactly. This is known as jugular foramen. Jugular foramen. The name is there because of the internal jugular vein which passes from there. Okay, jugular foramen. It may be a difficult question, and many of the time, we will ask some easier question than this. Many of the time, this big foramina is asked to the student. What is the name of this foramen? The big one.
Foramen
Magnum.
Magnum.
Exactly, foramen magnum. So what I'm saying here is just give around 5 minutes time. Okay, look at the base of the skull and try to recognize the important foramina there. Okay, because this type of questions can be asked in the different exams. So jugular foramen. Now number 11, we'll go to some other types of question now. In the developing embryo, this question was already done probably, but still it's like a revision for you. Stylopharyngeus muscle and hide bone is developed from a pharyngeal arch. Which of the following cranial nerve is associated with this arch? What is the answer among?
A.
Why you say A? Yes.
Because stylopharyngeus muscle is supplied by glossopharyngeal nerve.
Excellent. Very good. That is the very important reason he has given. Stylopharyngeus is the muscle which is supplied by glossopharyngeal nerve, and that's why the associated nerve has to be the glossopharyngeal one. And hyoid bone is also developed from the third pharyngeal arch. The nerve for third pharyngeal arch is glossopharyngeal nerve. Number 12, a 35 weeks old baby is seen by you as his doctor. His mother tells you that he is breastfeeding well, but he's sleepy all the time, but has wet diaper. Lab investigation are as follows. Sodium 128. Look at the normal range 135 to 145. Potassium 7.5 milliequivalent per liter. Normal range is 3.5 to 4.5. So the most probable diagnosis in this boy is congenital hypothyroidism, growth hormone deficiency, congenital adrenal hyperplasia, or Conn syndrome. What do you think? What is going on here? Anybody?
Sir, C.
Yes. C. You think this is a case of CAH, congenital adrenal hyperplasia. Can you give me reason?
Sir, I got a clue from lab investigation, sir. The
Yes.
sodium level is low and potassium level is high. Sir, in CAH there is decrease in aldosterone too, sir, which main
Good.
function is to excrete potassium and retain sodium. So in this case, this thing is given, sir.
Good. So this is, you think this is a case of congenital adrenal hyperplasia, where there is deficiency of aldosterone or mineralocorticoid deficiency. And another clue here is very small baby, isn't it? This is just a 35-week-old baby, not even 1 year. And this disorder usually presents at this age. It may present later on if we fail to diagnose, but this is another way of presentation. Absolutely correct. Okay, congenital adrenal hyperplasia, and the reason which he has given is absolutely fine. That is the way. The cell bodies of the nerve carrying gustatory sensation from the anterior two-thirds of the tongue are located in which of the following ganglion? Now, this is a bit of anatomical question again. See this gustatory sensation from the anterior two-thirds of the tongue are located in which ganglion? Is it pterygopalatine ganglion? This is palatine. Okay, please correct the spelling. Otic ganglion, geniculate ganglion, or trigeminal ganglion? What is the answer?
Sir, I think geniculate ganglion because of 7 nerve supply, facial nerve supply.
Okay, so you think it's a geniculate ganglion because of connection with 7th cranial nerve. Any other student want to say something here?
Sir, trigeminal ganglion, sir.
Trigeminal ganglion. Why you say trigeminal ganglion?
Because anterior two-third of the tongue is supplied by 5th cranial nerve. The gustatory sensation is carried by the 5th cranial nerve, sir.
Are you sure? Are you sure about that?
Yes, sir.
Now wait. Now let me clarify the important points here. Okay. So all of you, please pay attention. Now our tongue has got different types of nerve. Now tongue, the motor nerve for the tongue is, which is the motor nerve? Let me ask this question now. What is the motor nerve?
11, 12 cranial nerve, sir.
Exactly. Hypoglossal nerve, hypoglossal or 12th cranial nerve. 12th. Okay, 12th cranial nerve is hypoglossal. That is a motor. The motor is done. Now regarding the sensory, there are different types of sensation. One is called general sensory, okay, or general sensation like touch, pain, temperature. That is carried by trigeminal nerve. That is called general sensation, like a lingual nerve, which is coming from the trigeminal nerve. But this is a special sensation known as gustatory. Gustatory means taste sensation. Okay, so taste sensation is special, isn't it? So coda tympani is responsible for this anterior two-thirds of the tongue, and coda tympani is a branch of facial nerve. It's a branch of facial nerve. Now the ganglion which are connected with the facial nerves are different here. Pterygopalatine ganglion is also connected with facial nerve, and geniculate ganglion is also connected with the facial nerve. Otic ganglion is connected with 9th cranial nerve, that is glossopharyngeal nerve, and trigeminal ganglion is of course connected with the trigeminal one. Having said that, okay, some of the facial nerve may be connected here also, but according to the question which is given, the geniculate ganglion looks the most likely answer here. Pterygopalatine is especially connected with the lacrimal type of function, means the tear or the nasal one. These are pterygopalatine ganglion connection. Okay, let's move further. Okay, now number 14, chromosome 22 11.2 deletion syndrome include heart defect, poor immune system function, a cleft palate, complications related to low levels of calcium in the blood, and delayed development. Which syndrome is most likely here? Straightforward question.
DiGeorge syndrome.
DiGeorge syndrome. What is DiGeorge syndrome?
Sir, it is known as 2211 deletion syndrome, sir.
Very good.
And symptoms of this child is like heart problems, and facial features are also there, and developmental delays and cleft palate sometimes, sir.
Yes. Now, he's absolutely right. So this is the important clue for you is this low level of calcium. Now, do you know why this low level of calcium is present in this patient? What is the reason for this? That is a clue for you. That is because of poor development or incomplete development of the parathyroid gland. Parathyroid gland. Because in case of hypoparathyroidism, there is low level of the calcium. And this DiGeorge syndrome is associated with incomplete development of the parathyroid gland and the thymus. Okay, because of the uh, 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 thymus problem, there is poor immune system function, and because of decreased development of the parathyroid gland, we have low levels of the calcium in the blood, and other things occurs there. If you remember like this, it's easy for you. So DiGeorge syndrome. Now, number 15. In a developing embryo, neural crest cells are formed adjacent to the neural tube. These cells undergo migration. Which of the following structure is derived from these migrating cells? Can you choose one of them from the list? Which one?
So dura mater.
Yes, which one?
Dura mater.
Dura mater. Any other student? Now see here. To answer this, you need to remember what are the derivatives of neural crest cells, and from this list, sympathetic neurons are derived from neural crest cell, and adrenal medulla is a modified form of sympathetic neuron. Okay, modified form of sympathetic neuron. Regarding the meninges, okay, pia mater is definitely derived, arachnoid and pia definitely derived from the neural crest cells, but dura mater is not. So the answer is D here, adrenal medulla. Number 16. Now this is a bit of clinical one, and I'm sure every student can diagnose it. Please go through it. We already done this type of cases in some other way, okay? But this is a clinical description. An 18-year-old female patient presents to the emergency department stating that over the past 24 hours, she has developed left-sided facial weakness and drooping, inability to close her left eye as well. She is unable to move both upper and lower side of her face. The patient's vital signs are within normal limit. She is suffering from shingles. So what is the diagnosis? Straightforward question. Yes?
Ramsay-Hunt syndrome.
Ramsay-Hunt syndrome.
Exactly. This is Ramsay-Hunt syndrome. It is associated with herpes zoster. Shingles means herpes zoster. So all the features are shown here. Left-sided facial weakness because it leads to lower motor neuron type of facial problem. Okay, so because of that, she was not able to close her left eye. The whole one half of the face is paralyzed. And the strongest clue is shingles here. So this is Ramsay-Hunt syndrome. Now, what is malignant otitis externa, which is written here? What is the causative agent of this?
Sir, it is caused
Sir,
by fungus infection, sir. Or pseudomonas. Sorry, sir.
So it is caused by pseudomonas. Okay, malignant. Yes, malignant otitis externa is caused by pseudomonas. And this is a very serious type of infection at that area, and it is a damaging some bones also there, and it can rapidly spread to the nearby area. So treatment is a bit of challenging here. Others are quite easy for you. Okay, what is cholesteatoma? Before I move further, let me ask this: what is cholesteatoma?
It is a type of villi type which can compress the bone in these structures and may cause temporal.
Yes,
sir.
Yes. Please.
Sir, it is a non-cancer skin growth, sir, which mainly develop in the middle ear, usually behind the eardrum, and it develop as a sac or cyst, which compress other structures around, sir.
Exactly. Okay. So both of you have the concept, and I'm sure every other student also have. This is an important question from ENT, especially the ear part. Cholesteatoma is a type of squamous epithelium which is trapped inside the skull bone. In this case, inside the middle ear cavity. Okay, in the mastoid bone or middle ear cavity, if there is a trapping or entrapment of squamous epithelium, we call this cholesteatoma. This squamous epithelium is an active type of epithelium which is present there. It can erode the bone. It can erode the bone. There are different types: congenital cholesteatoma and acquired cholesteatoma. So please prepare that topic quite well. Not only the ENT doctor or ENT surgeon, but any other teacher can also love to ask that question to you. Let's move on. So this is Ramsay-Hunt syndrome. Another one, increase urinary 5-hydroxyindole acetic acid is a biochemical marker of which of the following condition? So look at the name of this condition and tell me the answer here. Anybody?
Carcinoid tumor.
Carcinoid tumor is absolutely correct, because these carcinoid tumors are which substance is secreted by them? Which substance?
Serotonin.
Serotonin. Exactly. And this 5-hydroxyindole acetic acid is another term for serotonin. Okay, another term for serotonin. See this is an indirect way of asking question. So a bit of difficult question probably if you do not know this name, but if you know this now onwards, actually do not make a silly mistake in this type of questions. It's quite easy one. Which of the following tumor is incorrectly listed with the marker? Now you may need a little bit of time here. The question is incorrectly listed with the tumor marker. So let's go through them. HCG and embryonal carcinoma, AFP and hepatic carcinoma. See there, catecholamine metabolite with neuroblastoma, CA19-9 with cervical carcinoma, and CEA with colonic carcinoma. So which you think is an atypical one? Which you think is not matching with each other?
Sir, it's D.
So you think it's D, carbohydrate antigen 99 and cervical cancer, right?
Yes.
Okay. Any other guys? I'll come to you, Eunice. Wait, any other? Is absolutely correct here. Now see this beta HCG is associated with hydatidiform mole, choriocarcinoma, and any other germ cell tumor. Embryonal carcinoma is a type of germ cell tumor. Alpha fetoprotein, hepatic carcinoma, hepatocellular carcinoma, catecholamine metabolite in neuroblastoma, because this tumor is obtained from the adrenal gland. CA19-9 is specifically related with pancreatic cancer.
Pancreatic.
Very good. Pancreatic cancer. Okay, don't forget that. And carcinoembryonic antigen, it may be present in colonic carcinoma as well, but it is a very non-specific. It is seen in so many other cancers. The answer is D. Now, number 19. Which of the following is characterized by the presence of red blood cells in the urine, high urinary urobilinogen, but no urine bilirubin? Now, see this. Take a bit of time here, okay? Presence of red blood cell in the urine, high urinary urobilinogen, but no urine bilirubin. So which one among these is the correct answer here?
I think, sir,
Yes. What is the answer according to you, Khatir?
sir, Gilbert syndrome.
Okay, what is Gilbert syndrome?
Sir, in Gilbert syndrome, there.
Yes, yes.
Sir, in Gilbert syndrome, there is There is also deficiency of enzyme, but also there is some bilirubin, maybe unconjugated bilirubin changed to bilirubin.
Mm-hmm. Okay. Any other answer? Okay, I'll come to you. Now let me clarify this for you. Okay. Now tell me, urobilinogen is formed where? Where is the place for synthesis of urobilinogen first? It is synthesized in
In
our,
intestine, sir.
very good,
Intestine.
in the GI tract or intestine. So to form or to synthesize urobilinogen, there should not be any obstruction of the bile flow. Yes or no? Yes. So those conditions which leads to obstructive jaundice, okay, are ruled out here. Gallstones are ruled out. Probably they result, in obstructive jaundice. Okay, we hope, though they may not. If they are inside the gallbladder, they may not lead to obstructive jaundice, but they are some of the important causes of obstructive jaundice. Then other things can still be there. Biliary cirrhosis, because there is no real obstruction. Even hepatitis, there is a component of obstruction, but it is not completely blocked. Okay, so these things still be there. Another clues are also there for you. Presence of red blood cells in the urine. Sickle cell anemia or sickle cell disease, okay, can lead to papillary necrosis inside the kidney. They lead to involvement of the papilla, which we call renal papilla, which are present in the kidney, and then they can cause hematuria, that we know. At the same time, it's a type of hemolytic anemia, so there is no problem in the flow of bile into the intestine, and there is no problem in the formation of urobilinogen. But this is unconjugated bilirubin, so why should we appear in the urine? Now let's move on. Please focus. In which metabolic bone disease are serum values of calcium, phosphorus, and alkaline phosphatase generally all normal? Is it osteoporosis? Is it osteomalacia? Is it hypoparathyroidism? Is it Paget's disease of the bone? Or is it osteitis fibrosa cystica? Which one?
Option A.
So you want to go for option A. Okay. Now, option A, osteoporosis. What is osteoporosis, by the way? Yes.
Sir, it is senile process in which the bone become weaker in old age.
Okay. One of the causes is senile osteoporosis. You're right. Yes. And
Yes.
usually there is no problem in, calcium, phosphorus, and other type of minerals there. Okay.
Yes, sir.
That is a good explanation. Now let me ask some other question before we discuss the answer here. What is this last one? Osteitis fibrosa cystica.
Sir, it occurs in chronic renal diseases, sir.
Very good. Excellent.
Yes, sir. It is one of the complication of CKD.
Yes. This is seen in chronic renal failure or chronic renal disease or chronic kidney disease. And this is also known as secondary hyperparathyroidism. Secondary. Okay. Because of, chronic hyperphosphatemia, there is a hypocalcemia, and that hypocalcemia will stimulate parathyroid gland to release more parathyroid hormone. That parathyroid hormone will act on the bone, and inside the bone, this type of changes occur. So these are called osteitis fibrosa cystica. Remember, this is a very important pathological term in case of secondary hyperparathyroidism, which is commonly associated with chronic kidney disorder. This is also known as renal osteodystrophy. That is another term. Paget's disease of the bone is a condition which occurs in very old people. And here there is, imbalance between bone resorption and bone synthesis. There's imbalance. More bone synthesis than bone resorption. So there is deposition of a bone in different parts of the body. Okay, it's quite irregular type of bone deposition, and sometimes that bone deposition can, give pressure to the nerves also. So different types of neuronal problems are very, very typical in Paget's disease of the bone. There is arteriovenous fistula also present inside these bones. So it can also result in hyperdynamic circulation that can cause cardiac failure. Paget's disease is one of the cause of cardiac failure. Hypoparathyroidism, okay, it doesn't present like this at all, isn't it? Osteomalacia is a vitamin D deficiency situation. So of course there will be decrease in calcium. So answer is osteoporosis here. So this is the way, you can reach to the diagnosis. A is the answer. Now, a bit of lab investigation question. The hepatitis serology results listed below are most consistent with, okay, which of the following option? Let's go through this first. HBsAg is negative. HBcAb IgM is positive. This is hepatitis virus core antibody, okay, IgM type is positive. HBsAb is negative. So this is antibody against the surface antigen is negative. And HAV antibody IgM, now this is for the hepatitis A virus, is negative. So according to this, which one you choose? Is it past infection with hepatitis B? Is it acute infection with hepatitis B? Is it chronic infection with hepatitis B? Or is it acute infection with hepatitis A? Just analyze and tell me.
Sir, B, acute infection with hepatitis.
Yes, so he is going for acute infection with hepatitis B. That's B option. Okay. Why you chose that option? Give me one reason.
Sir, because the core antigen is present in the acute infection, and after some week, the hepatitis surface antigen will be positive after.
Okay. Absolutely correct. Okay. See this IgM antibody is mainly positive in acute infection. And this IgM antibody is positive against hepatitis B core antigen here. So there is no point of choosing hepatitis A here. Okay, so this D is ruled out. Chronic infection is also ruled out. In chronic infection, we usually have IgG type of antibody. Okay, and the past infection with hepatitis B, usually we have hepatitis B surface antibody positivity. So all these things points towards this acute infection with hepatitis B. So if you are still confused here, I suggest you to go through this hepatitis B topic. Okay, there's a table which is given everywhere, even in my presentation earlier, which I taught you. There also this type of things are there. So just revise. This type of questions can be asked very commonly in your exam. So the answer is B here, because IgM antibody is present and it is against the core antigen. So this is acute infection with hepatitis B. Straightforward question now. Niemann-Pick disease is caused by deficiency of which enzyme? What is the name of that enzyme?
Sphingomyelinase.
Absolutely. This is known as sphingomyelinase. Very good. Sphingomyelinase is the name of the enzyme. Because of this, the different types of lipid are deposited in reticuloendothelial system, and the central nervous system. Sphingomyelinase is the answer. Now, another clinical question. If you see the triad of cirrhosis of the liver, hemochromatosis, and diabetes mellitus, what do you call that condition? Just a
Bronze
clinic,
diabetes.
just a clinical name. Okay, that is known as bronze diabetes. Absolutely correct. This is known as bronze diabetes, and that bronze diabetes is actually caused by hemochromatosis. Okay,
Yes.
because this is the abnormal collection of iron in the body, and that iron is damaging the beta cells of the pancreas, which results in diabetes. So the same condition can lead to cirrhosis of the liver also. So when we combine all these teachings together, we call it bronze diabetes. So this is a common question in different exam. Bronze diabetes. Now this patient is on spironolactone and ramipril together. So this is an ECG of this patient. So what's the diagnosis here?
Hyperkalemia.
Hyperkalemia.
This is a case of hyperkalemia. But what can you see on ECG? What is that arrowed part
Sir,
shown?
Sir,
Tall
the
TV.
peak T wave and the small QRS complex, and in there is a difference according to the level of potassium, sir.
Yes.
Sometimes it also shows the ST depression.
Exactly. You're absolutely right. Both of them. This is tall, okay, and peak T wave. Tall and peaked T wave. See how tall it is. In comparison to the QRS complex, it is very tall. Okay. This is a very, very important feature of hyperkalemia. Hyperkalemia. And this one, see this, okay, this one, though I cannot see any P wave here, okay, probably they want to see prolonged PR interval, or there is a, probably bradycardia or something like that they want to show here. But the important feature is this one. And another clue here, both this spironolactone and ramipril causes hyperkalemia as their side effect. Spironolactone is a potassium sparing diuretic. So potassium, okay, is spared in the body, or that means it is elevated in the blood. And ramipril, what type of drug is ramipril? Which drug is this?
ACE inhibitor.
Exactly, ACE inhibitor. ACE inhibitor. So the side effect of ACE inhibitor is also hyperkalemia, and this is a very poor combination actually. But from the examination purpose, we can ask this type of question to the student whether they know the things or not. So hyperkalemia. Now, for the treatment of hyperkalemia, you can use so many different drugs. So what is the drug of choice, or the first drug you give if a patient is showing ECG feature? Which drug?
Calcium gluconate.
Excellent. Calcium gluconate is the first drug. After that, I can use any other of the other drug. And some of those drugs push the potassium into the cell, and some of the drug will excrete potassium out of the body.
Yes, sir.
Now, can you name those drugs which will push the potassium into the cell? Which are those drugs?
Insulin.
Insulin and beta agonist.
Insulin and beta agonist like salbutamol. Wonderful. One more drug is sodium bicarbonate that also do the same thing. Insulin always given along with glucose, then salbutamol, which is a beta agonist drug, and then sodium bicarbonate. These three drugs will push the potassium into the cell. And then which are the drugs which excrete potassium from the body? Which are those?
Furosemide.
Loop diuretics and thiazides.
Yes, loop diuretics are the most powerful one. Though thiazide also do the same thing, but thiazides are a bit weaker than that. So we usually go for loop diuretics. Okay. And another way, what is another way? How to remove?
By dialysis.
Yes, another is dialysis. Very good. Hemodialysis. Wonderful. And third one is exchange resin. You can use exchange resin, which exchanges sodium with potassium. Okay, like sodium, okay, polystyrene sulfonate is the exchange resin, which can be used through enema route. So these are the different things. So immediately, whenever the term of hyperkalemia comes, your teacher may ask question like this. Remember that. Let's move on. A patient is diagnosed with nephrotic syndrome with renal vein thrombosis. Which of the following drug is the best option for the treatment of this renal vein thrombosis from the list? Is it heparin? Is it low molecular weight heparin? Is it warfarin? Or is it tissue plasminogen activator?
Warfarin.
Option C.
Option C or warfarin. Why warfarin? Why not heparin?
Because
Because
thrombosis
in
is also excrete. So heparin is working on antithrombin 3. If antithrombin 3 is not present, so heparin will not work.
Okay, so he's saying antithrombin 3 is getting excreted in the urine. So without antithrombin 3, heparin cannot function. Yes, absolutely. Okay, this is the reason. So you don't go for heparin in the treatment of a thrombotic disorder in nephrotic syndrome. Rather, we use warfarin. What is TPA, by the way? What is this
tissue
drug?
plasminogen activators.
Transplasminogen activator.
Tissue plasminogen activator. Okay, very right. Tissue plasminogen activator. Okay, so this is altogether a very different type of drugs. This is actually the drug which is used to dissolve the thrombus. Now, name the test which is shown in the picture.
Tuning fork test.
Tuning fork test, but which one of the tuning fork test is this?
Bone.
Rinne test.
Yes, this is called Rinne test. Very good. This is known as Rinne test. Okay. Now see there, this is the tuning fork test. There are different types of tuning fork tests we can do, like Rinne test, Weber test, absolute bone conduction test, and all those things. Okay, but this is Rinne test. So now I'm not sure whether you have gone through this or not, but I'm sure you have because you have already done ENT. So why Rinne test is done? Yes, can anybody tell me why it
To
is done?
check the air conduction and bone conduction will be otitis media.
Good. Okay. Yes. Any other explanation? Good, Khatir. Anybody?
Sir, it is done usually to evaluate the loss of hearing in one ear, sir, to check the bone conduction versus air conduction, sir.
Absolutely. Both of you are telling it correctly. Rinne test is done to check whether air conduction is still better than bone conduction or not. Or you can also say it like this. It is one of the tests when a patient complains of hearing loss. If this is a conductive type of hearing loss or sensory neural type of hearing loss, to differentiate, one of the tests we can do is Rinne's test. Now, let me explain how it is done. First, we vibrate the tuning fork, and the base of the tuning fork is attached on the mastoid bone, which is located right posterior to the pinna. This is called mastoid bone. Okay, ask the patient to raise the finger when the patient stops hearing. Then immediately when the patient stops hearing, I will bring the top of the tuning fork right in front of the ear and ask the patient whether you can still hear or not. If the patient say I can still hear it, that means ear conduction is better than bone conduction, which is normal. Air conduction is better than bone conduction. It is normal. It is normal in people, and this is normal thing because air conduction is always better than bone conduction. But in case of conductive hearing loss, bone conduction will be better than air conduction. Okay, this is known as Rinne negative test. So these are the different types of interpretation you can do. Okay, wonderful. Let's move on. Now, see there. Now, look at this picture, and question is, what happens to the blood sugar level? Well, first, I need to diagnose what is the condition from this picture, and then solve the question. Yes.
Acromegaly, and sugar level will be increased because of growth hormone.
Very good answer. Excellent answer he has given. He has given the reason as well. This looks like acromegalic patient. He's right. Look at the face here. Very coarse type of face, and all the tissues or organs look bigger here. Big nose. Okay. This overall appearance is very typical of acromegalic. Look at the hand. They are comparing with the probably the examiner's hand with the patient hand. This is acromegalic hand. This is a normal hand. Okay, so clear cut case of acromegaly, and in acromegaly there is increased blood sugar level because growth hormone is excessive here. You can also say this is one of the cause of secondary diabetes. So blood sugar level is high. Name the test. This girl is suffering from dry eyes. So which test they are performing here?
Shesky.
Schirmer test. Schirmer test.
Exactly. This is called Schirmer's test. Right here in the first class, we discussed about Schirmer's test. This is called Schirmer's test. See there. This is a small, paper which is inserted in the conjunctival sac, and after 5 minutes, we see how much length of this paper is weight. Okay, and this is how we interpret Schirmer's test. Now tell me, in which disease we usually do Schirmer's test? Which disease is that?
Keratoconjunctivitis sicca, Sjogren syndrome, or
Sjogren.
This is called
dry eye syndrome.
Very good. This is known as Sjogren syndrome or keratoconjunctivitis sicca or dry eye syndrome. Whatever answer you want to give, that is the correct one. Excellent. So this is called Schirmer's test. This patient is an IV drug abuser. Okay, and the gross specimen is shown here. This is a real specimen from the patient's heart. This is the heart valve actually. See this? And these are the pathological thing which is developing on the heart valve. So what's the diagnosis?
Infective endocarditis.
Acute infective endocarditis, which is caused by Staphylococcus aureus, which is most common in IV drug abusers.
Okay.
And the wall mostly affected in IV drug abuser is tricuspid wall.
And vegetation is occur.
Very good. So the answers are absolutely correct here. If you say this is a case of infective endocarditis, that would be fine. But if you say acute infective endocarditis, that is even better because there is a clue given to you, that is IV drug abuser. In IV drug abuser, easily Staphylococcus aureus infection is quite common. Okay, and that can lead to acute type of infective endocarditis, and he's right, it is more common in the tricuspid valve. Absolutely common. So you look at the big vegetations here, and these are destructive type of vegetation. They can quickly lead to damage of the valve, and then regurgitant lesion. Regurgitant lesion are quite common in this disorder. Now, acute infective endocarditis can occur in a native valve, means normal valve, which are not priorly damaged. But subacute infective endocarditis always occur in the priorly damaged valve. This is one big difference. Streptococcus viridans are the common causes of subacute type of endocarditis, whereas Staphylococcus aureus is the cause of acute type of endocarditis. Regarding the prognosis, acute infective endocarditis carries the worst prognosis here, or poor prognosis in the patient. Without treatment, they can collapse quite quickly. And there is a high chance of death as well. Another question, which drug is used to decrease the craving of smoking? So which is that drug? You have to choose from the list which is given to decrease the craving of smoking in chronically smokers? Is it buspirone, amitriptyline, bupropion, amphetamine, or methadone?
Bupropion. Bupropion.
I mean, bupropion, C. Anybody else?
C.
See, he is going for C. So what about other students? Yes, it is C. Is right. This drug is called bupropion, okay, which is specifically used to decrease the craving of smoking. Now, if somebody is chronic smoker, then it is difficult to immediately, stop smoking because it leads to withdrawal type of reaction. So this drug really helps in that situation. Okay, so bupropion is the answer. Now, name the sign which is shown in the picture.
Trososign.
Trososign.
Yes, this is called Trusu sign. So it is seen in which condition?
Hypocalcemia.
Hypocalcemia.
Excellent. This is seen in hypocalcemia. Hypocalcemia. This is a Trusu sign. Very typical. Never forget this. This is a typical type of presentation. And see there, the blood pressure cuff is kept here. Okay, and after we take the blood pressure and put the cuff like this for a few minutes, then Trusu sign will be elicited. Clear-cut case of hypocalcemia. Now, this is not the end of the diagnosis. I need to find what is the cause of hypocalcemia. Now, can you tell me what are the common causes of hypocalcemia now?
Decrease taking of calcium in diet, vitamin D deficiency, hypoparathyroidism, hypomagnesemia.
Excellent. He's answering
hyperphosphatemia.
Exactly. Wonderful
Kidney
way.
disease and
Very
malabsorptions also.
excellent. So they are answer almost all the important causes of hypocalcemia here. One is malnutrition. Okay. Another one is hypoparathyroidism. Hypoparathyroidism. The parathyroid glands are not developed, or they are damaged or destroyed. Okay, something like that. Then chronic kidney disease. Yes, is right. Chronic kidney disease. There also occurs chronic type of hypocalcemia because there is hyperphosphatemia. So this phosphate will bind with free calcium and it will lead to hypocalcemic situation. Don't forget vitamin D deficiency as well here. Vitamin D deficiency is an important cause of hypocalcemia. And one important situation is alkalotic environment, either respiratory alkalosis or metabolic alkalosis, especially the respiratory one, which is very common. If somebody breathes faster, okay, for a few minutes time only, they can wash out their carbon dioxide and environment will be alkalotic inside the body that can really leads to hypocalcemia and leads to this type of feature. Now, this condition is treated by the use of acyclovir and analgesic. Now, the question is, name the organism which causes this disease.
HSV.
This disease.
Varicella zoster virus.
Okay, so HSV and varicella zoster. So which one you want to go for? Yes, Yunus, you are saying varicella zoster. Yes, Khatir.
Sir, herpes simplex virus.
Why you said herpes simplex? What are you seeing there? Yes.
Sir, because of the type of rashes and
and now.
Sir, I forget.
Okay,
Sir,
no
it
problem.
is.
Yes,
It is also called the herpes zoster virus, so that's why maybe he is confused with this name, sir.
Okay, no, here. The condition is known as shingles. Okay, shingles or herpes zoster. Herpes zoster is name of the disease here. It is not the name of the causative agent. So let me write it very Will you hear this? This is known as shingles or herpes zoster. But the causative agent is varicella zoster virus. That is the causative agent here. It is varicella zoster virus. Never forget it. Quite confusing question for the student if you do not pay attention. Every time when we ask this type of question, the student can make a mistake. Yes, herpes simplex virus can be considered as a differential diagnosis, but there are certain points which are strongly in favor of shingles here. Look at the type of distribution. This is known as dermatomal distribution.
Dermatomal pattern.
Exactly, dermatomal pattern. It's a very, very important point for shingles. And especially in case of herpes simplex virus, more of a vesicular rashes or eruption would be there. I cannot see any vesicle here. Okay. Let's move on. Now, number 33. This is a type of non-Hodgkin's lymphoma, and it is more common in equatorial country. Look at the picture and give me the diagnosis.
Burkitt lymphoma.
Yes, sir. Burkitt lymphoma.
Absolutely correct. This is Burkitt lymphoma. This is the Burkitt lymphoma, which is present in the head and neck area. This is a very, very typical picture. Okay. Any surgical book is having this type of picture. So once you see, you'll never forget. Burkitt lymphoma. But sometimes, okay, retinoblastoma may appear not exactly like this, but it may appear in the same area, like in the orbital area. A huge type of growth may occur from the orbit, not exactly on the cheek area, but somewhere here. So look at your question clearly or properly and answer. Okay. Sometimes you may be confused. This is clear-cut non-Hodgkin's lymphoma is given, so it has to be Burkitt's lymphoma. Retinoblastoma is not a type of non-Hodgkin's lymphoma. What is the cause of this? What is the causative agent?
EBV.
Epstein-Barr virus.
Exactly. Epstein-Barr virus is the causative agent of Burkitt's lymphoma. Now see there. Another question. Rhizus sardonicus, trismus, and muscle spasm are seen in this neonate. What is the diagnosis?
Tetanus.
Neonatal tetanus.
Yes, this is a case of neonatal tetanus. See, this is a neonate, so we add the term neonatal tetanus here. And this Rhizus sardonicus, what do you mean by that? What do you mean by this term?
Smiling face, like
Smiling
clenching the
face.
jaws.
Yes, smiling face. You can simply say that. It's a smiling face because of the contraction of that area there, it looks like that baby or the person who is suffering from tetanus is smiling all the time. What is trismus? Trismus.
Lockjaw.
Lockjaw. Excellent. Lockjaw. The jaw cannot be opened. And one very, very important point we love to tell our students or the young doctors or the new doctors is, whenever you are trying to examine the patient of tetanus or you are trying to intubate the patient, do not put your hand inside the jaw. Sometimes a sudden spasm may come, and after that you cannot take your hand out of the patient mouth. It is trapped there. You may lose fingers sometimes. It is that strong type of spasm. That is called trismus, lockjaw, and muscle spasm are quite common feature here. So, what is the causative agent of this disease?
Clostridium tetani.
Clostridium tetani. It's a type of anaerobic organism. It is
Yes,
type of anaerobic organism. So, which
gram.
toxin is causing all this problem? What's the name of the toxin?
Titanospasmin.
Exactly. Titanospasmin. Now tell me what you do regarding the treatment. What we need to do in treatment?
Sir, we have to do supportive treatment in this condition, sir. Firstly, giving the diazepam to the patient to decrease muscle spasm, and also we can give the tetanus immunoglobulin if he or she is not vaccinated. In this case, probably he is not vaccinated, so we can go for TIG, and later on we can give tetanus vaccine also
Exactly.
if he
Absolutely
requires.
correct. Absolutely. So
And
there are,
also we can go for some breathing support, like, because sir, maybe in this condition respiratory system may also compromise, so we can go for supportive management.
absolutely, all the things you are saying are important part of the management. Absolutely. So there are two types of management you can think about. One is supportive and symptomatic treatment, and another is a definitive treatment. Now, this child is having breathing difficulty, so secure the airway first. Okay, endotracheal tube is very much necessary here. That will secure the airway. Okay, then another one, there is a constant spasm are coming. Sometimes even seizures may be there. So diazepam is one of the important part of the management. We need to relax the muscle, and diazepam should be given a very good dose. And remember, excessive amount of diazepam can result in respiratory depression. But once you have secured the airway, you don't need to worry about the respiratory depression. We can easily, give bagging to the patient if respiratory depression occur, or we can even connect the patient to the mechanical ventilator. But most important point is stop those spasm of the muscle. At the same time, we need to kill those bacteria which are causing the problem. So antibiotic are important part of the management, and antitoxin is also important here. That antitoxin will help to neutralize the toxin which is not yet fixed on the nerve. Now, the toxin which is already fixed on the nerve, we cannot neutralize the toxin. But if the organism is still there, and if that organism is constantly releasing the toxin, we can neutralize the toxin by giving antitoxin. So all of these are important part of the management. Now, let us make this as a last question for today. A patient with severe abdominal pain and bleeding per rectum, and this is the laparotomy or laparotomy picture of the patient. What is the diagnosis? What do you think? What is going on here?
Sir,
Just describe what you see there. What can you see in the picture? Yes.
sir, there is a feature of ischemia given there in statement, sir.
Good. So very good. So you think this is a ischemic bowel. Okay. So
Yes, sir.
what can you see here? What is the color of this bowel?
So it's more darker, like you can
Yes.
say the necrosis type, sir.
Yes, it is more darker than the normal. See this. This is the normal bowel. You can clearly see it. Just compare. This is a normal bowel, and see how dark is this. Okay, heavily congested and a little bit going towards the black color as well. So this is a clear-cut case of ischemic bowel. Okay, this is also known as mesenteric ischemia. When mesenteric artery or superior mesenteric artery or inferior mesenteric arteries are blocked, then this type of feature develops in the bowel. Okay, mesenteric ischemia, and this is a typical clinical feature: abdominal pain, which is severe one, and then there is bleeding from the rectum. This is a fresh, a bit darker type of blood, but this is not melena. Melena is a different type of bleeding there. Now, what should we do for this patient? What is the treatment?
First thing is to diagnose, and another is immediate laparotomy and remove the necrose part.
Exactly. Remove the necrose part after resuscitation and do end-to-end anastomosis.
End-to-end anastomosis.
Exactly. That is the treatment.